I am Jerimiah Chakaya Tililindo. I am a medical doctor by profession, and I'm a pulmonologist. Pulmonology means I am specialized in lung diseases, and among those lung diseases is tuberculosis. We consider tuberculosis a pulmonary disease mainly, and that's what I do. Tuberculosis is a very old disease, or rather we have known as humans. We have lived and known tuberculosis for very many years, and it has been and continues to kill a lot of people in the world. Currently, in 2022, for example, the World Health Organization estimated that more than 10.6 million people developed TB worldwide. And tuberculosis was responsible for about 1.2, 1.3 million deaths globally. So it is a problem that has been with us for a long time, continues to be with us, and therefore it's important to have this conversation. Tuberculosis affects anyone and everyone. There is no human being who can say that they are immune to TB infection and TB disease. However, there are certain groups of people that for various reasons have a higher risk of being infected with TB and having the TB progress to disease. And if it's not treated, having a higher risk of dying from tuberculosis. So it is the enormity of the problem that makes it important that we have conversations about TB. So you can divide vulnerability to TB into two groups. There are those who are socially vulnerable to TB, and these are usually people who are poor and who are living in situations that are socially deprived situations. So the poor globally have an increased risk of TB. These include people living in, for example, urban slums. If you're talking about Nairobi, for example, it'll be people living in Kibera, people living in Mathare, people living in Kawangware, and so on and so forth. And then you have people who live in refugee camps, for example, migrants. These are individuals who are poor, and because of that poverty, they are living in human conditions, that are, or rather in conditions that are not healthy, and consequently, they have problems of food insecurity. A lot of people living in those in those situations will be undernourished or malnourished. They may have poor access to health services, and when they access health services, those health services may be suboptimal or not high quality services. They may be living in poor houses, which are poorly ventilated, very dark inside, so poorly lighted and poorly ventilated. And they are also living in a situation that one could consider as being crowded or overcrowded. So all those factors together makes these individuals socially at risk of developing tuberculosis. Now that's one group. But you also have people who have what we call clinical risk factors for TB. These are individuals who, for some reason, have low immunity. And they may have low immunity because they have, for example, HIV infection, or they are diabetic, or they have chronic kidney disease, or they are being given medicines by their doctors to treat something that lowers, whose treatment lowers immunity. For example, a lot of people in this world, or even in our country here, require sometimes to be given long-term systemic steroids. These are medicines that are used to control inflammation in the body, and if you use those for a very long time, you then are at risk of developing TB because your immunity is low. So therefore, In summary, you can't divide people into those that are socially vulnerable. They are vulnerable because of societal factors. And then you have those that are clinically vulnerable because they have something that lowers their immunity and they cannot control TB infection, as it were. Dangerous, yes. Dangerous in many ways. When you suffer TB, of course you are sick. And because you're sick, you won't be able to work, so there are social and economic consequences. But also there are physical consequences. You feel awful, you got symptoms, and if you don't get treated, or if there are delays in getting treated, you can even die from the disease. Or you can be treated eventually, you can be identified and treated eventually, but have long-term complications because there were delays in being identified and being placed on treatment. So yes, it is a serious problem. So because it is a serious problem, all of us are urged to be aware of the problem of TB. And if we feel like we could have TB, we need to seek care as quickly as possible. And the most common symptoms of TB include fevers, when people start developing hotness of the body, when people start having drenching night sweats. You go to bed and you start sweating so much that your clothes and your beddings become wet, or if you're losing weight. Those are pointers that something is not right in the body, and that something that is causing a problem could be TB. Now, tuberculosis affects mainly the lung. 85% of people with TB have disease in the lung. That's why the pulmonologists are at the forefront of fighting this disease. But it can also affect other parts of the lung, or other parts of the body. So, because 85% of people with TB have TB of the lung, the most common symptoms, in addition to the fevers and the night sweating and the loss of weight and the fatigue and malaise and all those things that are common with illness, you also get to have lung-specific symptoms, like, for example, coughing out blood, having difficulties in breathing, having chest pain, those kind of things. However, 15% to 20% of people with TB have TB outside the lung. We call it extrapulmonary TB. And for those with extrapulmonary TB, the symptoms will be specific to the part of the body that is affected. So if the brain is affected, very commonly there will be a headache, there can be convulsions. If it is in the intestine, for example, the abdomen may be swollen and painful. If it is in the urinary system, there may be pain on urination, and so on and so forth. It all depends on the system that is affected. So like I said before, 80 to 85% of people with TB in the world have lung TB. But 15 to 20% of people with TB have extrapulmonary TB. And then there's a small group of people who have both. You can actually develop both TB in the lung and TB outside the lung at the same time. So dual pulmonary and extrapulmonary TB. This can happen. Also, when you are treated for TB, or when one is treated for TB, there is, for some people, an increased risk of developing TB again. And you might start off with lung TB and then develop TB in another organ. Or you can start with TB in another organ and develop lung TB later on, because the risk of recurrence in those who have been treated for TB before is higher than in people who have never been treated for TB. So if I get treated for TB, I have a slightly higher risk of developing TB again, as opposed to somebody who's never had TB. The ideal is healthcare workers need to be very familiar with how TB presents and should take every opportunity to identify people who could have TB. And therefore, when I walk as a person, I walk into a healthcare facility, I should be screened for common diseases, including TB. And therefore, healthcare workers have been trained and are being supported to identify people who may have TB by doing what is called a simple screening system of asking people, are you coughing, do you have a fever, do you know, those kind of things. Where possible, it's really, really important to get chest x-rays done. Chest x-rays are very good at identifying people who need to be tested for TB. As a screening tool, it's a very, very useful tool. It's very, very sensitive. It will pick up those who need to be tested for TB very easily, as it were. And nearly everyone who has TB, of the lung at least, will have an abnormal chest x-ray. Once you've been identified as someone who could have TB, then you need to be tested. And that test usually in our country is a sputum-based test. So you produce a specimen of sputum, makohozi, we call it, and that makohozi then goes to the lab and is subjected to appropriate TB testing. That appropriate TB testing, ideally, in the world should be based on identifying the DNA of the germ that causes TB. We call it in our language molecular testing. So that is the best. That is what should happen. Screened for TB either using symptoms or X-ray, and if you've been identified to have TB using either of those, get TB tested ideally to identify whether your sputum has DNA of the TB germs. And if your sputum has DNA of the TB germs, you should then be treated for TB. The repercussions, there are many repercussions. Again, at the societal level, remember, tuberculosis is an infectious disease. What does this mean? It means that the person with TB, especially TB of the lung, can transmit their TB to other people. They can transmit it when they talk, when they laugh, when they sing, when they sneeze, when they cough, and so on and so forth. Therefore, if a person has TB and they are not identified quickly and they are not placed on treatment quickly, that individual will infect other people. And that's how TB is sustained within the population, as it were, because people are taking long to be identified to have TB. By the time they identify to have TB, they've had a big opportunity to transmit their disease to other people. And we want to stop that transmission by identifying people as early as possible. So that is at the societal level. And then at the individual level, if TB is not identified, it can kill, or it can lead to long-term complications, even after it has been treated. So you are treated for TB, you get cured, but you have in terms of the germ has been removed from the body, so you've killed the germs, but you end up with long-term complications that you live with for the rest of your life. And that is also something that we don't want to happen to people. World over, except in a few countries, men are affected a lot more than women. However, that dichotomy, that difference tends to happen after the pubertal years. So in the early years of life, if you look at children, it may be equal, same number of children who are male versus same number of children who are female get TB. But when you get to the teenage years, you start seeing a separation with slightly more, or rather significantly more males than females. It is not that females don't get TB, but males get more TB than females. Now, we are not quite sure why that is so. There may be biological factors that are operating in the human population that somehow increase the risk of TB in males, although the bulk of it is probably driven by behavior. Males tend to do things that are often not done by women, for example, tobacco smoking, for example, alcohol intake, for example, delays in TB in seeking care because people are working and they have to take care of their families, and so on and so forth. So these factors may be responsible for the significant higher rates of TB in males compared to females. It may be behavioral, but biological factors may also be extremely important in driving those differences.